Another question coming back to this issue of bridging anticoagulation, let's say multiple dental extractions. What about the advantages of NOACs because they metabolize quickly with respect to avoiding bridging? Could you?
No,
could
it's
you
a
touch on
great
that?
question. One of the things, these patients who have venous thromboembolism or even stroke prevention atrial fibrillation, they tend to be older patients. Most of these patients are going to have a procedure. All of these drugs have much shorter half-lives than warfarin. And so in most patients, you could simply stop a drug 24 hours, at most 2 days before a procedure, and the blood thinning effects are gone. So unlike warfarin, where you'd have to stop warfarin 5-7 days before a procedure, for most patients you could simply stop the drug 1 or 2 days before, and that depends a little bit on their underlying kidney function. All these drugs are renally cleared. If someone has impaired renal function, you may have to stop a little bit earlier. But this is really one of the advantages, that these drugs work so quickly. As soon as you take a pill, within 2 hours you're fully therapeutic, but they're also out of the bloodstream soon, which is a real advantage for patients who need elective and urgent surgery. And then just to follow up on the Einstein, which is the rivaroxaban data, again, against placebo, 82% reduction in venous thromboembolism, so remarkably better for an extension study. And importantly, when we look at Amplify, which I think was very encouraging, not only did they see the 80% reduction against placebo for extension therapy, but apixaban, studied in 2 doses here, actually had very similar bleeding to placebo. So these drugs are much safer, in my opinion, for long-term therapy, because if you're going to give a blood thinner indefinitely or for a long period of time, you want to be using an agent that doesn't cause excess bleeding.
You know, that's such an important point, and you and I both have our ears to the ground, and we have busy practices ourselves, and we speak to physicians from all over the country, and there is this lingering perception that the NOACs might have more bleeding, but the evidence is just the opposite.
Exactly the opposite. And I think when you're talking about long-term or indefinite therapy, we know the fear of bleeding really drives our decision, and we tend to undertreat patients. But I think that this data really has compelled me that we, for the most part, need to be treating our patients with VTE longer, because every time they look with any drug that you can pick, patients tend to do better. Warfarin for extended treatment lowers events by 95%. The other drugs we've talked about today, rivaroxaban, apixaban, dabigatran, all lower recurrent events by 80 to 90%. These patients are at tremendous residual risk. So if we stop therapy, many of these patients, as you said, go back to this elevated risk. Even aspirin is very effective. Not as good as a traditional blood thinner, but in landmark Warfasa and Aspire studies reduced recurrent VTE by 32%. So in the end, I think for most patients, we should be considering whether we need to treat longer.
Right.
And this is still a hot topic of debate.
It sounds like the message is great efficacy with the NOACs, far better than that with low-dose aspirin.
Far better.
And surprisingly excellent safety,
Right.
far better than sometimes the street reputation would have it. Now, we have of the multiple dozens and dozens of questions, a recurrent question. I'd say this sort of encapsulates half a dozen viewers asking you, Christian, for a clear explanation for the significantly lower rates of bleeding of the NOACs compared to warfarin in both the VTE and AFib populations.
I think there are probably multiple reasons for this. Now, the most important thing is the data speaks to itself, so everything I'm going to say is sort of hypothesizing. But one thing we know is warfarin, although it's very effective, it's incredibly difficult to use. And so we know, and this is in a recent study, I know, Sam, that you're familiar, that even in the US today, if you look at warfarin, how we're able to get them in a time and therapeutic range between 2 to 3, we only were able to achieve that about 55% of the time, which I know you like to say this, in any high school in America you go to, that's an F.
Yes.
And so when you don't use warfarin well and patients are constantly above and below 2 to 3, that predisposes patients to bleeding. And so we know, because warfarin's so hard to get right, that those patients are often under and over anticoagulated, and that really predisposes you for bleeding. one of the things about these new agents, they have very predictable anticoagulant effects, and they've been studied so that you can give them in a specific dose. Sometimes you need to lower the dose, and there are indications in the labels for all of them, but that dose gives you very defined anticoagulation levels, so you don't have too little, and importantly, you don't have too much. And that is why we see such dramatic reductions in serious bleeding. Also, there's something fundamentally different about the biology of these drugs, that they cause less bleeding in the brain. And it may have to do that these drugs target only a single enzyme in the clotting cascade, where warfarin tends to interfere with your ability to clot all over the place. And so what's very reassuring is that the consistency has been found across the different drugs and in both indications, venous thromboembolism and AF. So I think this consistency of safety is something that we can really believe in.
Now, in time's just flying by, but I have to ask you again some of the questions that at least half a dozen of our viewers are asking. And this has to do with cancer patients who have DVT or pulmonary embolism. Could you review with our viewing participants the issues regarding cancer patients? First of all, they weren't excluded from any of these pivotal trials.
I think that's important. First, to highlight that we know patients with active malignancy, particularly solid cancers, are at very high risk of VTE, very high risk of recurrent VTE. So this is a very high-risk patients. They were not excluded from any of the trials, although they were relatively a small proportion in each of the large trials that enrolled for VTE. But the data in the cancer patients appears to be the same. There doesn't appear to be, when you look at the subgroups of the trials, any lack of efficacy into cancer patients with malignancy. So I think that there is certainly no data that says that these agents are not effective in those patients. We know that often the standard of care for cancer patients is not even warfarin, but extended therapy with a low molecular weight heparin, because these patients are at such high risk. And we know, because warfarin is very hard to control, that with warfarin, these patients long-term, if they're relatively under-anticoagulated, their risk is so high in these patients that the predictable anticoagulant effect of low molecular weight heparin is preferable over the variable efficacy of warfarin. But remember, the NOACs are sort of similar to low molecular weight heparin in that you get a very predictable anticoagulant effect. And so I myself feel no reason to doubt that these drugs would not be effective in patients with cancer. Certainly cancer patients were enrolled in these trials, but I do agree it'd be nice to have a more robust experience of using these agents in a population that had cancer, a much bigger study. And those studies I know are being planned.
Now, while we're talking about special populations, and this is one of my pet peeves, there's a lot of street talk saying, well, if a patient has factor V Leiden or prothrombin gene mutation or the lupus anticoagulant, you shouldn't use a NOAC. But correct me if I'm wrong, none of these were excluded from the trials. They didn't expect a patient to come in with an acute pulmonary embolism and then have blood tests sent away to a lab on the other side of the country to work up a thrombophilic states. So thrombophilias were not excluded from any trial. Of the trials.
These trials did not discriminate to subsets of patients with pulmonary embolism or DVT. They were a very broad population, people who clotted, provoked DVT, unprovoked DVT, thrombophilia. All of these patients were included in these trials. This was a very broad representative population.
Okay, and while we're talking about safety, and this question really hits the nail on the head. Most clinicians, or many clinicians, are afraid of bleeding with NOACs because they believe bleeding with warfarin is easier to manage. I'm going to ask you, as this viewer does, to comment on that, not only bleeding in VTE patients, but bleeding in AFib patients.
Yeah, let me talk about bleeding in general quickly. And we could spend a whole hour on this topic as well. This is a real misinformation. First of all, that we can reverse warfarin. There is no real antidote to warfarin. We can give vitamin K or fresh frozen plasma that does correct the lab abnormality of warfarin, the prolonged INR, but there's never been a study that once a patient has a serious bleed, by giving any of these agents that we improve outcomes. For example, in patients who have an intracranial hemorrhage on warfarin, the cat is out of the bag. That once you've bled there's so much devastation, and there's no evidence that these late administration of reversal agents works. The one thing we know is that all of these agents cause half as less serious bleeding to begin with. So you're much better off preventing half of the bleeding rather than cause twice as many serious or life-threatening bleeding and then try the best you can to reverse it. And remember, all of these agents are very short-acting, so they're out of the bloodstream in 12 to 24 hours. So simply stabilizing the patient, quickly the anticoagulant effect is gone. And we do have some agents that we can use that have been at least hypothesized to work, such as prothrombin complex concentrates. But I think overall, these agents, as studied without a reversal agents, cause so much less fatal and life-threatening bleeding that that should be our goal, prevent bleeding from occurring in the first place. I will say that specific antidotes will likely be available for all these agents in the next 1 or 2 years. There are some very promising compounds being developed that have been in expedited regulatory approval pathways for the FDA. So an antidote is coming, but we shouldn't not use these agents in the interim because they cause so much less serious bleeding to begin with.
So really, tincture of time is our friend.
Exactly. Exactly. The short half-life of these drugs is the most compelling message.